Well, good afternoon, ladies and gentlemen. My name is John Deanfield from London, and on behalf of my co-chairman, Peter Libby from Boston, welcome to this very exciting session that we're going to have, entitled Evolution of Coronary Artery Disease Diagnosis from Stenosis to Inflammation. And this title reflects the tremendous change in our understanding and management of coronary artery disease over the last 10 years, during which time we've moved away from just looking at stenosis in coronary arteries to understanding that the vascular biology, particularly inflammation, plays a huge role not only in driving this disease in terms of its development, but also in determining its risk. We have two key speakers this afternoon, and what we're going to do is ask them to give their talks and then have an adequate session at the end where they will both sit together and answer any questions. So without any further ado, I'm going to ask my co-chairman, Peter Libby, to introduce the first speaker.
Well, it's wonderful to see this turnout for a topic that is near to my heart, which is the imaging of inflammation. And I'm very pleased to be joined here by my colleague and friend, Ron Blankstein, who's a professor of medicine and radiology at the Brigham and Women's Hospital, Mass General Brigham. And he is an exponent of our jointly shared program in cardiovascular imaging between radiology and cardiology. And this is an experiment that you guys should try here in Europe, because the 15% of the time that people spend in turf wars, we can put towards building program. And Ron is a wonderful example of the productivity of that joint imaging program. Ron?
Thank you. What a pleasure to be part of this session. And I'm going to kick off by talking about the evolution of coronary artery disease diagnosis. When we diagnose coronary artery disease, of course, there's a lot of tools we can use. On this slide are all the different methods we have. On the top are anatomical approaches, and on the bottom are physiologic or stress test approaches. And of course, to visualize coronary disease, we can start with a plain chest CT or a calcium score or coronary CTA, or leading all the way to our invasive angiography. When we do stress testing, whether it's a nuclear stress test, an echocardiogram, or a stress MRI, we're now looking for flow-limiting disease. It's really the tip of the iceberg. It's only the coronary disease that's significant enough to limit blood flow. But of course, a big question that we have to ask ourselves is, why is it important to diagnose coronary disease? And of course, if I ask my interventional cardiology colleagues, and this is a depiction of what they look like according to ChatGPT, the answer is they just want to know who needs a stent and who doesn't need a stent. Now, if you ask preventive cardiologists, and I think most clinical cardiologists, we would say, well, the reason it's important to diagnose coronary disease is because there's a lot of interventions we can do to prevent coronary-related events. They range from lifestyle interventions to medical therapies, whether weight loss interventions for diabetes medications, more aggressive lipid lowering, or anti-inflammatory therapies. Now, this is a very exciting slide for those who are interested in prevention, because we have so many more therapies today than we ever had before. And the other really good piece of news is that we know that medical therapy works really, really well. And I think one of the best examples of how well it works comes from the ischemia trial that took individuals who had stable coronary disease, who had at least moderate ischemia on stress testing, and it randomized them to an invasive strategy or a conservative therapy based on prevention. And of course, as most of you know, this trial showed no difference in outcomes. And I think this is really a trial that shows the power of preventive medical therapy and medical therapy. So with that, I do want to talk about the different ways that we diagnose ischemia or coronary disease and talk to you about the pros and cons. First, when it comes to ischemia detection, it's important to know that the absence of ischemia does not necessarily mean low risk. So you can have a completely normal stress test, irrespective of what modality it is, an MRI or an echo. And the reality is that many of these patients may have underlying coronary atherosclerosis, such as this case here. This is a coronary CTA showing diffuse, mostly non-calcified atherosclerosis in this individual who had a normal stress test. The other important point is that when we use nuclear imaging, we often will underestimate the severity of disease. The reason for this is that in nuclear imaging, we're looking at relative differences in blood flow. So even if we see perhaps mild ischemia and we think this person has one vessel disease or just mild disease, that can often be the case when someone has multi-vessel disease. So this is a consistent theme. The other very important point is that most stress tests that we do today are normal. This is a study from Cedars-Sinai in LA showing that 95% of stress tests for patients with stable chest pain are normal, 95%. And that is important because when we look at studies where patients had imaging and then went on to experience an event, we know that most cardiovascular events occur in individuals who had a normal stress test. And it's not that the stress test is wrong. The stress test is designed to detect flow-limiting disease. It's just that, statistically speaking, there are so many patients with normal stress tests, and some of them may have significant underlying plaque. The other very important point, and we've seen data now from multiple studies, is that the amount of plaque that individuals have may be more important for determining prognosis than whether or not they have stenosis. And in fact, once we account for the amount of plaque, whether a patient has stenosis or not, may not add to prognosis. So these are the limitations of ischemia detection. What about trying to detect obstructive disease? And I think in cardiology, we've generally had a kind of an obsession on diagnosing stenosis, whether on invasive angiography or CT. And there's important limitations to that. First, there are patients who have non-obstructive plaque, especially if it's extensive, who may be at higher risk. And if we rely on obstructive disease to tell us who are high-risk patients, we're going to miss the boat. The other very important point, and this was shown recently by a study that Dr. Antoniades is going to talk more about, the orphan study, is that most events occur in patients who have non-obstructive coronary disease. Okay, so in the orphan study, there were twice as many events in individuals who do not have obstructive disease than those who have obstructive disease. And of course, if you have obstructive disease, you're high risk, but there are so many more patients with non-obstructive disease. And if we don't treat those patients, or if we cannot identify which ones of them are high risk, we miss an opportunity to initiate treatment earlier. Let's talk about coronary CT angiography. One of the advantages of coronary CT is that we can detect both obstructive and non-obstructive disease. We can detect both calcified plaque and non-calcified plaque, and on this slide is a nice example of non-calcified plaque in the proximal LAD. And of course, we can detect the whole spectrum of stenosis on this slide, going from left to right, ranging from minimal, mild, moderate, or severe stenosis. So if our goal is to detect stenosis, we can do that. But one of the things that we now have to do every time we look at a coronary CTA is not just to identify stenosis, but also to report how much plaque is present. This is the CADRADS 2.0. This is a document that clinicians and imagers should use to report the findings of CT. And the reason why this is 2.0 is because 1.0 had something wrong. 1.0 did not have any information on plaque quantification. And in version 2.0 now, what we state is that every CTA should be interpreted with respect to the amount of plaque that individuals have. There's different semi-quantitative and sometimes qualitative ways to look at a CT and assess how much plaque there is. This is, by the way, not based on fully quantitative plaque detection. That's coming in the pipeline as well. But the message there is that when patients have severe amount of plaque, our recommendation is to treat those patients with aggressive prevention. And this is actually supported now by guidelines. In our chest pain guidelines in the US, we now state with a class 1 indication that when patients have non-obstructive coronary disease, it is recommended to optimize preventive therapies. And the chronic coronary disease guidelines in the US also, we now know that imaging, and specifically anatomical imaging with CT, can be used to diagnose coronary disease and decide which patients to treat with some of our therapies. Now, when we talk about plaque, a natural question often is, what about patients who are asymptomatic? And how prevalent is it that individuals have plaque? And the largest study to show this is the SCAPUS study from Sweden, showing that 42% of individuals, and these are individuals between the ages of 50 to 64, had underlying atherosclerosis. In the US, the largest asymptomatic cohort that's been followed is the Miami Heart Study, showing similarly about 50% of patients have plaque. So plaque is widely prevalent, but we do need approaches to know which individuals who have plaque are at higher risk. With that background, let's turn our attention to inflammation. We do know that when patients have plaque, that plaque starts in the endothelium, it develops in the endothelium, and it can progress over time. One of the really important points, and Dr. Libby has really taught us all of this, is that inflammation may lead to plaque development, progression, and rupture. So you can have plaque that over time is stable and have a thick fibrotic cap, or you can have a plaque that's exposed to inflammation, and that can result in plaque erosion and a more unstable plaque. So inflammation may be a key way to know which plaques, or which individuals rather, have a higher risk and are going to be more prone to have events. With that, the big question, I think, and we're going to get some answers to this, is can identifying inflammation by coronary CTA enhance the detection and treatment of coronary disease? And really the main principle here is that when there is inflammation in the coronary arteries through direct signaling with the pericoronary adipose tissue, there's lipolysis, which is the breakdown of fat, there's edema, and we can detect that signal by looking at the fat around the coronary artery. Essentially, as Dr. Antoniades has taught us, and will speak soon, this perivascular adipose tissue can act as a biosensor for vascular inflammation. This is something that we can now measure on every coronary CTA. You don't need to do anything special during the acquisition. You can take any CTA that's been acquired and perform this analysis. And importantly, having an abnormal fat attenuation index is associated with a much higher risk of a myocardial infarction, and this is incremental on top of amount of plaque and high-risk plaque features. So this is a very exciting technology. So in conclusion, the diagnosis of coronary disease has shifted from invasive to non-invasive techniques. Of the available tests, coronary CTA has the highest accuracy to detect plaque or stenosis, and currently it's the only test that's been shown to improve patient outcomes in randomized trials, which is why it has the strongest level of evidence in guidelines. A challenge that remains, however, is that most patients who undergo coronary CTA will have non-obstructive coronary disease. That is the most frequently encountered finding after coronary CTA. And the underlying risk among this group is highly heterogeneous. Given that, the ability to detect inflammation has been shown to improve prognosis and may emerge as a key factor in how we manage patients who are at risk for coronary artery disease events. Thank you.
Well, thank you very much, Ron. We're going to go straight on to the second presentation. It's my great pleasure to introduce Charalambos Antoniades, who's a professor of cardiology at Oxford in the UK. And Harris has really taken the science of CT scanning onto another level, using this technique not just to demonstrate these beautiful anatomical pictures, but to take this fat phenotyping and to use it to try to characterize the biology of atherosclerosis. So, Harris, tell us about inflammation risk and cardiovascular events in patients without obstructive coronary disease, clinical and economic evidence of FAI scoring, and the AI risk model.
Thank you, John, for the introduction. Thank you, Peter, for co-chairing. It's a great pleasure to be here with you. These are my disclosures. So Ron has done a great job to introduce the topic. He has convinced us that inflammation is very important in the development of atherosclerotic disease. We also know that it's a treatable target, therapeutic target, so we can give colchicine, we can give statins, and that suppress inflammation, and this is how these drugs partly work. Now, the big question, of course, is how to identify the patient with vascular inflammation who will benefit from this kind of anti-inflammatory treatments that are now in the guidelines. Colchicine has an indication in both the European and the US guidelines for high-risk individuals. How do we find the people who really need these treatments? We have circulating biomarkers, we have high-sensitivity CRP, IL-6, TNF-alpha. which are good tools for screening the general population because they are just measured in the plasma, easy, cheap. However, I think we can do better if we have in our hands the right tools. And the big question is whether we can measure inflammation inside the human coronary arteries in a way that will guide us to decide who needs these anti-inflammatory treatments. As Ron has said, coronary CT angiography is the only test that tells us whether there is coronary atherosclerosis because it visualizes directly the plaques in the coronary arteries. And from the orphan study, we know now that 2/3 of the heart attacks happen among the people who do not have obstructive coronary artery disease. So the people that we see in our clinics who have chest pain, they have a coronary CT angiogram, they have either absolutely no disease or maybe some minor plaque here and there. These are the people who give 2/3 of the heart attacks in the healthcare systems. So this is important to keep in mind. Now, with coronary CT angiography, as Ron said, we can now visualize coronary artery inflammation by looking into the fat surrounding the arteries, the coronary arteries. In this black and white picture that you see here for coronary CTA, the fat appears as black, so you don't really see the fat. However, we develop a method that is called fat attenuation indexing that brings this information to the surface from routine CT angiograms, coronary CT angiograms, and then you can appreciate that if there is no inflammation in the artery, then you have this yellow color around the artery. That's the healthy fat. If there is inflammation in the coronary artery, then you get this red color. And if you see in this case that I present on your right, this is a late presenting STEMI. This is a highly inflamed plaque, and you can see how the perivascular fat becomes red in the area with high inflammation as you move along the coronary artery. Now, when we first described this technology, this approach, we had to quantify it, and we developed the fat attenuation index. So in the CRISP-CT study, published more than 5 years ago, we have shown that if you have high inflammation in your coronary arteries measured by using fat attenuation index, which is a quantitative metric, then you had 5 to 9 times higher risk to develop a cardiac event compared to those below the cutoff. Now, after the first observation, we tried to turn this into a clinical tool, but of course the bar is very high to get attenuation readings on a CT and turn them into a standard label that will be regulatory cleared. So that led us to development of a standardized index that is called fat attenuation index score, which is essentially the only recognized biomarker in cardiac CT that has received the label by the European regulators and the UK for a biomarker of coronary inflammation per se. Now, there is a recent clinical consensus statement published by the European Society of Cardiology, the Working Group of Coronary Pathophysiology and Microcirculation, talking exactly about the need of standardization in having these measurements of inflammation by using routine coronary CT angiography. This is a useful paper. If you are interested in the topic, you can go through and see what are the recommendations of the working group. Now, when you have any kind of biomarker like this, then the big question is it validate enough? Can you replicate the results in different cohorts, in different continents, different scanners, different settings, etc.? So the orphan study was designed to do exactly that. This is the world's largest registry of coronary CT angiograms linked with outcomes data. At the moment, this study has 135,000 patients with up to 15 years follow-up, with the CT angiograms centrally processed in our servers in Oxford. The first paper published in The Lancet a couple of months ago included the first 40,000 patients, and in a sub-study of that, we measured the fat attenuation index score. And indeed, as you can see here from this very recent data, in a completely different population compared to the population of the training data presented 5 years ago, now if you are above the 75th centile of coronary inflammation in any artery, any of the 3 arteries, you have 20 times higher risk to die from a cardiac event and 6.7 times higher risk for MACE. If you focus now specifically on those individuals that we reassure in our clinics, those with no obstructive CAD, some of them with some plaque, some of them without plaque, then you see a very, very similar result. Hazard ratio of 10 if you're above the 73rd centile for cardiac mortality and 4.7 for MACE. Of course, another very interesting population is the really, really healthy, as we call them, individuals that have the coronary CT angiogram and they have no plaque at all. And if they have some irregularities of the lumen or some minor plaque, this is called minor atheroma, if any. And these are the ones with CATRATS 0 or 1. Now, in this population, the results were also rather shocking. You see that there is no power of 0 if you collect the outcomes data centrally in a healthcare system like the collection of data we perform in the orphan study in the UK NHS, where every event is recorded through national registries. You see that if you have high inflammation, even if you have 0 calcium score, you have a hazard ratio of 9.5 to have a fatal cardiac event, a 5.5 to have a MACE. Now, we talked about plaque earlier, we talked about inflammation. We know that we have our risk scores, the risk factor-based scores, like the ESC score, like the pool cohort equations in the US, the CaRi-Risk-3 in the UK. How can we take all this into account in order to decide, as clinical cardiologists, who is the patient who needs aggressive management and who is the patient who is at high risk? That's exactly the gap that we try to cover by using AI. So we have developed a prognostic model that integrates all of this information into a single metric, and I will call it the revised, the enhanced ESC score. It's an AI risk score, and this is how it works more or less. We received funding from the British Heart Foundation a few years ago, and we developed this application, which is accessible through standard internet connection. That application gets the CT angiograms, the coronary CT angiograms, extracts information about plaque, about inflammation. It asks from the clinician to enter the risk factors of the patient, and then it projects that into a prognostic model, and it gives you essentially a revised ESC score, the absolute risk for a fatal cardiac event. At the moment, it's over a period of 8 years, but now it's being revalidated for a 10-year period. Originally, the model was trained in the US population. It was validated in a German population, external validation with a very, very good performance, way above the predictive value of what you can get with ESC score or CaRi-Risk-3. There was, of course, the question whether you can expand this model and use it in healthcare systems like the UK healthcare system, which are significantly different to the US and different also to the German population. And this was something that was asked by NICE when they were reviewing this technology to be introduced into the NHS. So this is essentially the result of the orphan study that I presented earlier. If you look into the first line in this table, you will see that this new risk prediction model gives you an area under the curve, or 0.844. This is as good as one would expect from a prognostic model, and you can see that you reach really this state just by looking into inflammation in any of the 3 coronary arteries. The additional value of the risk factors themselves and the presence of plaque is small. Significant, but small. The vast majority of the risk seems to be driven by inflammation and seems to be captured by the FAI-Score, no matter where you measure it in any of the 3 arteries. For those who know about prognostic modeling, these are the calibration curves of the model. In the whole population of orphan, in those without obstructive CAD, the blue line is the ideal, and the red line is the true, is a predicted, essentially, calibration curve. And you can see that the model is very well calibrated to predict risk. Now, in clinical cardiology, we are very, very much relying on cutoffs. So we want to put our patients, right or wrong, we still want to put our patients in buckets. so that we make decisions. If you are above a cutoff, then you trigger certain action. And our guidelines, all the guidelines, US, UK, Europe, they all talk about categories of risk. You have the low, medium risk patients, the high risk patients, and the very high risk patients. And then based on the risk, you know what to do by looking into the guidelines. This is exactly what this prognostic model does. It positions your patients, taking into account everything, including the imaging information, into these three buckets. Now, in the orphan study, these are the predicted events by looking only into the baseline information and predicting events over a horizon of 10 years. Now, when we open the labels, these were the true events we observed. So the predicted events and the true observed events are shown as dotted and solid lines on this graph in the three buckets of risk stratification generated by this approach. So essentially, we can predict by using this approach nearly every event that happens, every fatal cardiac event. And of course, it works also for non-fatal. Now, if you look into the individuals without obstructive CAD, which is the most interesting group of patients, the vast majority of these patients don't receive any treatment. They are just reassured and they are sent home. Our model predicted this number of events. These are the dotted lines in the three groups in the low, medium, high, and very high risk group. And these are the true events observed after you open the labels 10 years later after the scan. And you can see that essentially you pick up nearly every event that was predicted. And of course, this goes on the top is a fatal cardiac event. At the bottom is the MACE that includes also the non-fatal. Now, how to act upon this information in practice? Well, you just apply the guidelines. If you know what the risk of your patient is, and you know that the risk is very accurate, then you just follow the guidelines. The guidelines say, start studying, increase the dose of studying, go to maximum dose if you are very high risk, consider other lipid-lowering treatments, consider colchicine, although the guidelines don't tell us when. They say very high risk, but these are exactly the guidelines that we can implement by using this type of approach. And indeed, patients, this is from a study published a few months ago, after 1 year of studying treatment, the predicted risk coming from this model is reduced by 40%. This is more or less what you expect, what you have seen in the randomized clinical trials in the past, a reduction of 40% in the risk for fatal and non-fatal cardiac events. On top of maximum dose of studying treatment, if you treat your patients with biologics, and in this randomized clinical trial published again a few months ago, it was found that treating your patients with monoclonal antibodies against antioxidase LDL, of course this is just an example, even within 12 weeks leads to a further 40% reduction of the risk for events, for MACE, predicted by using this model. This is on top of the 40% already achieved with treatment with statins. This technology is now in the NHS. It has been found to change management of 45% of the patients in the healthcare system of the UK. And essentially, these are the predicted reduction of events in a model of 5,000 patients over a lifetime period. So there is an 11% of predicted reduction of myocardial infarction events and another 12% reduction of cardiac death. And in a health economic analysis, this is also cost effective with an ICER of 1.3 thousand pounds when the cutoff that NICE has set is 20,000 pounds. Just to close with an example, this is a typical patient that we see very often in our clinics, an absolutely normal coronary CT angiogram. These are the patients that we will normally reassure. This is a patient that had actually 25 times higher risk to die from a cardiac event over the next 10 years, and this is a patient who actually developed an event. Just to close, to summarize, inflammation is a therapeutic target in prevention. Coronary inflammation can be measured with coronary CT angiography, routine CCTA using the FAI-Score. The integration of all the information, including inflammation, into a risk model is there, is available, and applying it in a healthcare system is cost effective. I would like to thank all my colleagues, my co-investigators in the orphan study, and all of you for being here to present the result to you. Thank you.
So, Charis and Ron, could I have you join us up here on dais? Well, this morning I chaired a session on small trials in inflammation, and it was fully attended. And I made the remark, because everyone started their talk by saying that inflammation is very important in cardiovascular disease, by saying that if we'd had this meeting 12 years ago, there would have been the speakers and their close relatives. So here I see a robust audience with 3 or 4 layers of standing room only. So I think that the idea of inflammation and ways of estimating inflammation has come of age. Let me invite speakers to either send us their questions on the internet tool or come to the microphones. And I see one eager questioner at microphone 2. Please. I'd like to ask all the questioners to tell us who they are and where they're from.
See, since inflammation is so important in coronary artery disease, do you think that colchicine will replace aspirin in the future along with statin high dose? Will the aspirin will be replaced by colchicine?
Ron, do you want to take that one?
I think the question, if I heard it correctly, will aspirin be replaced by colchicine? Is that right? Yeah, I think for our high-risk patients, the answer is no, because I think they're kind of different pathways. I think of aspirin as an antiplatelet for antithrombotic. So if I think patients with a high risk of atherosclerosis, MI, and stroke, I would still use both colchicine and aspirin together. Colchicine for the anti-inflammatory properties and aspirin for the antithrombotic properties. And of course, with aspirin, we always have to weigh it against the risk of bleeding. So that's a personalized decision for each patient depending on the risk.
Apart from the calcium scoring, is the HRCP not a very common tool for screening the people? Calcium scoring is actually one of the tools you mentioned, is very with artificial intelligence and all that. Which the CRP is not a common tool for screening the people.
I think the question is on calcium scoring for screening, at least for colchicine, if we're kind of talking about inflammation. The LODOCO-2 trial, one of the inclusion criteria was a calcium score over 400. So based on that, patients who have extensive atherosclerosis, we may consider them for colchicine. And interestingly, in that trial, they actually did not check CRP, so it was irrespective of the CRP levels.
And why did methotrexate fail in pulmonary
I'd like to give chance for other people to question. So microphone 1, and then we'll go to the middle of the room there.
I am Dr. Lara from Ecuador, and I would like to ask you, besides the inflammation or information of the angiotac, what is the value of the low attenuation information of the plaque? Because low attenuation is also a predictor of event. What's your opinion?
Yeah, maybe I can answer this one. So low attenuation plaque is a useful tool if you get it reliably. Of course, it's very variable from a technical point of view to get this information in a reliable way. So the low attenuation plaque is more likely to be inflamed, but it's not necessarily inflamed. In the orphan study, in the one that I have presented, that we published in The Lancet a few months ago, we corrected the prognostic value of inflammation measured by using this new AI technology for low attenuation plaque, and the needle didn't move. So if you know which artery is inflamed, whether there is detectable low attenuation plaque or not becomes secondary matter.
Thank you.
Then we'll go to the middle here and then to microphone 1 again.
Thank you. Maas Bastiaan, Belgium. Very interesting talk, really nice work. I was wondering, of course, before you can estimate the fat attenuation index, you need to do the coronary CT, right? So who are the patients that you would do this CT scan? Because other markers like high-sensitive CRP are maybe more readily available compared to more, a bit more sophisticated tests. Thank you.
Yeah, so all the data that we presented so far are done on coronary CT angiograms performed as part of clinical care, right? And the indication to have a coronary CT angiogram is chest pain. Now, if you are asking me if this will be applicable in primary prevention, I will say certainly yes. However, we don't have the hard data, evidence, to say that if you go out in the community and you start screening patients on the basis of, let's say, Q-risk3 or the basis of CRP, you will be able to get exactly the same result. So that's the answer. If you are doing the CT scan at the moment as part of clinical care anyway, then it's a no-brainer to perform this analysis. But we need more data for primary prevention in order to trigger the CT, in order to get the measurement.
So I'm going to summarize a number of questions that have come in through the internet. They have to do with whether or not we're measuring the same kind of inflammation with the fat attenuation index as one can gauge with the CRP, and whether we should use the results of FAI to allocate therapies. And the answer is that there's emerging data that is a mixture of basic science and clinical observations that suggest, while there's an overlap in the type of inflammation or the source of inflammation which these two modalities can report on, that there are distinct pathways that are reported on. So, for example, C-reactive protein can be engendered from synthesis in the liver from inflammation anywhere. It could be, for example, in adipose tissue or a fatty liver, whereas the FAI is looking right at the organ of interest, at the coronary arteries. And whether one should allocate therapy, and you've touched on that, I think this is a wonderful opportunity for new clinical trials, because we have to get past the one-size-fits-all approach and consider what biomarkers can identify individuals for specific therapies, including anti-inflammatories. Let's go to microphone 1 and then to 2.
Thank you very much. Brittany Weber, Boston, USA. Phenomenal lectures by everyone. And you already answered my first part of the question, Dr. Libby. But the second is I really want to ask, in your discussions, you said, colchicine, guidelines put it there, but they don't tell us when to use it. And you had a question mark on biologics. And there really is emerging data for a role for these therapies. But how do you envision what is needed to be able to get that evidence so in clinical practice we can actually make those decisions of when we add colchicine, and also as we think about polypharmacy, when we may opt to treat inflammation over, maybe a different pathway based on the risk with some of the biomarkers incorporating FAI?
Yeah, so great question. So the low-hanging fruit here is risk. If you are able to estimate risk and to define who is high risk, and you take inflammation into account in the calculation of the very high risk, and if you know that inflammation is the driver of this very high risk, so that's when you give colchicine under the current guidelines without even needing to reinvent the wheel. So you define the risk more accurately, driven by inflammation, and you treat. Of course, we need more trials to show that colchicine reduces the biomarker, or reduces inflammation in the organ of interest, in the coronary arteries, and then how sustainable this reduction in inflammation is at the long term. But of course, this is additional work that is good to have for the future.
Exactly. Thank you.
I'll just add, risk is really important, but just because someone's risk is high, the question is how do we modify that risk? And I think one of the interesting things about FAI and inflammation is not just telling us that the risk is high, but it may also tell us that part of that risk is mediated by inflammation, and therefore targeting anti-inflammatory therapies, I think, as Dr. Weber suggested.
To microphone 2.
Thank you. Lukas Kołtowski, Warsaw, Poland. Quick question. Is there additional predictive benefit of plaque burden? We know that large plaque burden is a predictive value. What's the situation adding that to FAI?
Yeah, so there is a result published on that in the recent Lancet paper, but it's in the supplement, so you'll find it if you go at the back pages. So essentially, when you add plaque on top of FAI-Score, it barely needs move the needle. So it's the additional value of plaque burden is small if you take into account inflammation.
Thank you.
Harris, it's quite interesting that in the Lancet paper, you had poor risk and high risk, even in the absence of any detectable plaque. So this idea that they are one or the other, you've got the biology going wrong, even in the absence of detectable or minimal detectable plaque. So you can't use plaque burden on its own in the way that's sort of been suggested in a lot of these people.
Yeah, this is what Peter has been saying always. So when does atherosclerosis start? Because you have inflammation at the beginning, and then you have the plaque develop later, but then you may miss the development of the plaque, and you may go straight to the event. So if you go early in the disease process and you pick up inflammation and you treat it, then you prevent plaque development. And of course, all these prognostic models, they look into a 10 years horizon, and the events happen after 5, 6, 7 years. So even if you don't have plaque at baseline but have inflammation, you may still have an event in 5, 6, 7 years. And if you do the angiogram at that point, you'll see that there is plaque at that point. You just didn't have it when you performed the original scan.
I don't think they're asking a question.
You know, one of my pet peeves is calling non-obstructive lesions minor or mild. And thank you, Ron, for showing my 2002 diagram that correctly showed eccentric outward remodeling. You can have a considerable burden of disease without encroaching on the lumen. And it is exactly those kinds of lesions that may provoke a plaque disruption or a fissure or erosion that can cause an acute coronary syndrome. So we should really, it's like expugning conservative therapy in ischemia. There's nothing conservative about contemporary medical therapy, and there's nothing mild about an eccentrically remodeled plaque. So I think we're coming to the end of the time, and I think we've covered the substance of many of the questions that have come in. I guess we have time for one last short question and short answer on three.
Ranjit Moore from Blackpool, UK. Can I just ask you about the dynamic nature of the inflammatory process with the FAI index? Is there any data to say how much variation you get over a time interval?
Yes, there is now a significant amount of data out there. We always tend to say, based on the biology, you need 6 months of treatment of an inflammatory agent in order to see changes in the signals. However, in a recent randomized clinical trial with the antioxidase LDL monoclonal antibody that I have shown earlier, they have seen striking effects within 12 weeks. So 12 weeks is the earliest time point that you can use if you have a very strong biologic that affects inflammation. But typically we say at least 1 year.
Okay, well, I think we've come to the end of a very exciting session. What we've heard today really does change the way in which we can take some of the exciting science that has emerged in the last 10 years and begin to apply it in clinical practice, not just to understand risk, but actually to make clinical decisions about treatment. So I think watch this space of some very exciting work that's going to emerge in the next 1 to 2 years that really will tell us how to incorporate this one-stop shopping technique in which we can image anatomy, flow, but now biology of atherosclerosis in a unique way that really will change clinical practice. I'd like to thank both speakers for a fantastic set of presentations, also my colleague Peter Libby for leading the discussion, and I hope you have a great rest of the ESC meeting in London. Thank you very much.